There we go. Now I'm unmuted. That's better. Are you all seeing my slides, or are you seeing my presenter view? Just check in. Just my slides. Okay, perfect. All right, I have no conflicts of interest. I'm also going to be talking pretty fast because I was told 15 minutes and I've got a lot of stuff that I didn't want to take out of the presentation. So we will just jump into it here. So after the presentation, you should be able to explain addiction potential of benzodiazepines, discuss complications of benzodiazepine use in patients with opioid use disorder, and identify appropriate use of benzos in patients with opioid use disorder. So to kind of make sure that we're on the same page to get started, what are benzodiazepines? So, you know, a few of them that we think of like off the top of our head. This is not a comprehensive list, but alprazolam or Xanax, clonazepam, Klonopin, diazepam. And back in the 60s, actually diazepam or Valium first came out in 1963, which ironically was the same year that The Feminine Mystique was published, which was kind of one of the things that they wanted to, who they marketed to. So with Mother's Little Helper, something to kind of help housewives get through the day, I guess. So how do they work? They bind to the, so we're going to get a little technical, but then we'll kind of bounce back out from there. But they bind to the alpha subunit of the GABA receptor, and GABA is a molecule that leads to inhibition of neuronal excitability. So all that basically to say the benzo binds to the alpha subunit of the GABA receptor and causes the amount of GABA that's there to work better. So kind of potentiates its effect, resulting in kind of a downer effect, and kind of some CNS depression and sedation. For people that are visual learners, this is what that kind of looks like. So you have your benzodiazepine that binds down here to the alpha receptor, causing, if we're going to get really technical, an influx of chloride, which reduces kind of the excitability of those neurons. So usually where we see benzodiazepines is in the setting of anxiety. They're actually considered to be the most efficacious medications for anxiety, generalized anxiety disorder, social anxiety disorder. However, that does come with some caveats and some risks that we'll talk about in a few minutes. It can also be used as an anticonvulsant to stop seizures. We use it a lot in alcohol detoxification, catatonia, insomnia is where we traditionally have used it in the past, although definitely not something I really recommend for insomnia on a regular basis. And then patients with manic and psychotic states. So for adverse effects, can cause, drowsiness, which tolerance can develop to that, ataxia, psychomotor impairment. So all this kind of goes along with the CNS depression aspect of the benzodiazepines, which is also sometimes why people use them, specifically for, you know, insomnia. They can cause some memory loss and then also that physical dependence. And as we talk a lot about here in Project Echo and just in the setting of addiction in general, the difference between making sure we understand the difference between kind of physical dependence. So if the medication is taken away, patients experience withdrawal symptoms versus addiction, where people are kind of seeking out and doing risky behaviors to get the substance of choice or use that they use. So as I said, it is habit forming. Some patients experience euphoria, and that can reinforce the use of benzodiazepines, but so can the efficacy of them. So if you are somebody that's really socially anxious and you feel kind of isolated because you can't go out and interact with people, but then you use a benzodiazepine and you can interact and talk with people and form relationships, that just reinforces the use of that benzodiazepine. If you get a euphoric feeling on top of it, even better. Additionally, you know, if you're having a hard time sleeping at night, you're not going to be 100% from day to day, right? So if you can use a benzodiazepine, get a good night's sleep, and then you feel well rested and a better version of you, that's going to continue to reinforce the use of the benzodiazepine. And then also, it potentiates effects of other drugs, specifically, you know, opioids. I had an acquaintance that I knew actually that said, you know, when he used to party, it used to be alcohol and benzodiazepines, because as soon as he took that Xanax, it would, you know, surprisingly, he said it would help keep him up the rest of the night and just really potentiate that buzz that he had. So when we're looking at some of the agents, the benzodiazepines that are more lipophilic get absorbed quicker, and they can kind of create, because of that quick onset, it's kind of a quick hit and a rush from those. So agents like this would be diazepam, and I didn't put chlordiazepoxide in here, but that's another one that would work there. And then it distributes into the fat tissue more quickly. So diazepam is considered a longer acting benzodiazepine, but that rush that patients feel is very quick and goes away relatively quickly. The more hydrophilic ones, such as lorazepam and oxazepam, have a little bit slower absorption and onset of action, but these are also generally considered to be shorter duration as well. So with the withdrawal, the longer duration of use, so we have some patients that have been on benzodiazepines for years and years, and it's harder for them to come off. They require a longer taper. Patients that have been on shorter can be taken off a little more quickly. And when tapering, it's recommended to decrease by 10 to 25% every 2 weeks. Now, this is just kind of a starting point for tapering the benzos. So for somebody that's been on a longer time, it could take months to get somebody off of the agent, and it's highly individualized how that's going to go. So with the withdrawal, the common symptoms that you're going to see: rebound anxiety, insomnia, restlessness, muscle tension, irritability. Less commonly, you might see seizures, which are obviously very dangerous. That's why you take somebody off of opioids, they're not going to have a seizure or really necessarily be at risk of dying. Whereas with benzos, we really need to make sure that we are tapering them off safely so they don't experience that. And a few other symptoms are listed there that I won't read off. All right, so I found this study it was represented in the National Institute of Drug Abuse, I think I might have said that wrong, the NIDA, sorry. But these were the most recent kind of statistics I could find with some benzodiazepine misuse. And they found from 2015 to 2016, 12.5% of US adults, and this is self-reported, so there are some limitations to some of this data as far as kind of reporting bias or what you might hear, but 12.5% of US adults had used benzos, 17.1% reported misusing them, and only 2% met criteria for benzodiazepine use disorder. And that's something that I kind of kept seeing pop up in the literature pretty frequently, is that surprisingly, benzodiazepine use disorder by itself is not a huge problem, but when we put it in combination with other substances like opioids, that's when it becomes really scary, and we'll talk a little bit more about that in a couple minutes. And the reasons listed for misuse of the medications were mostly, the biggest one was to relax or relieve tension, followed by insomnia. About 12% of people used benzos to get high, and then 10.5% said to help with emotions, and 5.7% to experiment. And like I said, benzodiazepines and opioids, not good. So really increases risk for overdose. And so the FDA relabeled both benzodiazepines and opioids, warning about risk for overdose with sedation, respiratory depression, coma, and death. And speaking of benzodiazepine co-involvement with overdoses, there was a study by Torrey and colleagues that was published really recently here in 2020 in JAMA, the JAMA Network Open, and they looked at benzodiazepine co-involvement with opioid overdose deaths, and from the period of 1999 to 2017, and you can see what a significant increase it was there, from 4% co-involvement in overdose deaths up to 17%. So it's pretty significant there. And here's just kind of some graphical representation of that. You can see all opioid deaths, as we know, increased significantly from 1999. And then they looked at benzodiazepine co-involvement and also alcohol co-involvement, and you can see both of those increased as well. With the benzodiazepines, they kind of peaked around 2010 and then fell off a little bit, but still, significantly increased from 1999. And then this is a graph that shows the percentage of benzodiazepine co-involvement with specific types of opioid subtypes. And we can see, and this is something that I think most of us are probably aware of though, but heroin is on the rise as well. Especially, I mean, it's definitely a multifactor. There are a multitude of reasons why that is, but you can see that synthetic opioids kind of fell off around 2013 as we started to become a little bit more aware of the opioid epidemic and how many lives it was taking. So buprenorphine, as we know, is used to treat opioid use disorder and is a partial opioid agonist. It generally has kind of a ceiling effect on respiratory depression, which makes it relatively safe. However, if you add benzodiazepines onto buprenorphine, that can remove the ceiling effect and increase the risk of respiratory depression and death. Plug for naloxone there, making sure that your patients, pretty much any patient that you have on an opioid, including buprenorphine, it's a good idea for them to have the naloxone, but very, very definitely if they also have a benzodiazepine on board. So there's a study by Park and colleagues in addiction that I found really fascinating. They were looking at all patients that filled buprenorphine from 2012 to 2015 in Massachusetts, and they did a retrospective chart review. And what they were looking at, they wanted to compare the groups of patients that had filled a benzodiazepine and those that had not. And their primary outcomes were fatal opioid overdose, secondary outcomes, non-fatal overdose, all-cause mortality, and then whether or not the patients discontinued buprenorphine treatment when they also filled a benzodiazepine. And what they found was significant results for all of these. Opioid overdose increased by almost 3 times, non-fatal opioid overdose doubled, all-cause mortality also almost doubled. And then very interestingly too, the patients that were not co-prescribing a benzodiazepine actually was kind of protective from people stopping their opioids. So if they got a benzodiazepine, they were more likely to stay on their buprenorphine treatment. And so here's some specific numbers for people who want to see it. So this is the fatal overdose rates per 10,000 person years. You can see almost 3 times there. If we move over to non-fatal overdose, almost doubled there. And then if we move over to all-cause mortality, also pretty much doubled there too. So some really interesting results. And kind of, you know, the takeaway from this study is that benzodiazepines and buprenorphine increase risk for fatal and non-fatal opioid overdose along with all-cause mortality. However, it also, patients who were not prescribed benzodiazepines had an increased risk for stopping buprenorphine. So then that kind of brings us to the question, is it better to hold or to keep people on benzodiazepines when they're prescribed buprenorphine and we know all-cause mortality is increased and this, that, and the other? Or, you know, on the flip side of that, if we don't prescribe the benzodiazepine, there's more of a risk of them potentially stopping buprenorphine and relapsing onto their opioids, which we also know increases their risk for death. So basically, you know, our takeaway from that is that it's really highly individualized, very patient specific, and a risk versus benefit conversation that we have to have with those people. So when I give a talk, I like to have some takeaways. And so when I was thinking about this, I was like, well, who would I use benzos in if it was a patient with opioid use disorder? Again, disclaimer, it is highly patient specific. It is going to be a tough conversation with them to weigh those risks versus benefits. Preferably, you would have them in a controlled environment where you can monitor them very closely, such as inpatient. And I would recommend maybe considering it in patients with really, really debilitating anxiety that has been unresponsive to other therapies. So, antidepressants, psychotherapy, counseling, a whole, try everything else before. But if somebody just really cannot function without it because of crippling anxiety, that might be a setting. Alcohol detox, again, that would be in the inpatient setting, catatonic patients, inpatient use for manic and psychotic states. And when you do use them, low dose, very clear instructions. And if you're going to prescribe it in an outpatient setting for, anxiety, it's important to have kind of an exit strategy. So making sure that we have the rules defined. If this happens or if it's not helping you, then we're going to stop prescribing this. So that way that's very clear up front. So monitoring CNS depression, respiratory depression, we're looking for falls, we're looking for difficulty breathing, we're making sure that our patients that have opioid use disorder and benzos have naloxone, check UDSs, pill counts, CSMD, some of the same stuff that we're going to use when we are treating patients with opioid use disorder in general. And in summary, benzos are habit-forming, potentiate effects of opioids. They significantly increase risk of overdose when combined with opioids and kind of remove that ceiling effect of respiratory depression with buprenorphine. So we're going to make sure that we're using our benzos very, very cautiously in patients with opioid use disorder. All right, I'm not sure if I hit 15 minutes or not, but what questions do y'all have?
You did a fabulous job, Ryan. Thank you very much. We do have a couple more people to introduce that have joined our group, but questions for Ryan. We'll take those and then we'll introduce the rest of our joiners.
Thank you, Ryan. I thought that was really helpful. This is just a broad question around any recommendations that would change specific to women that are pregnant.
That is a very good question. Let's see, around women that are pregnant, that I will need to kind of research that a little bit more and just get you a more nuanced. I hesitate to give an answer right now because I don't know if I'm as plugged into that information as I want to be to respond well to you.
Sure. Thanks for considering it.
Mm-hmm.
Does anybody on the call have a thought around pregnant women and concomitant benzo and opioid use disorder treatment meds? Marianne?
I was going to say also, Ryan, when you look that up, would you look into breast milk and transfer to breast milk from nursing moms? Because we also, in my area, have a lot of nursing mothers.
Absolutely, 100%.
I'm glad to hear you have a lot of nursing mothers, Marianne. That makes me happy to hear that. So I have a thought, and I look forward to hearing more from Ryan on the topic, but just thinking about from the standpoint of the neonate and withdrawal potential, the withdrawal from the benzodiazepines is something I would be concerned about. So I think trying to wean down a mother who's on a benzo when she's pregnant, I think that's definitely a conversation you need to be having with her. But again, everything is individual, but its impact on, truthfully, like impact on pregnancy as far as any teratogenicity, I can't pull that out of the top of my head. So anybody else who knows that, I'd love to hear what you know about that. But my thoughts go to withdrawal and just knowing that the benzos tend to be more challenging of a withdrawal picture for the neonate often than buprenorphine or other opioids is. So that's my thought on that. But does anybody else have any thoughts or knowledge to share on benzos and pregnancy?
Dr. Troxler, I would just agree with you that the withdrawal would be a little bit more severe, in that I would be concerned about the newborn potentially having a seizure from withdrawal.
Definitely. I think, yeah, totally agree with that. But I do think that it's a really excellent question, Caitlin, so thank you for bringing that up, and we can certainly get back to you on that and the group as a whole. In the chat, actually, Marianne, you'd asked about access to the slides, and Brian had provided the link to get onto that. So our webpage, if you just kind of scroll down on it, there's a resource link, and if you click on that, you can get into slides from previous sessions as well as today's. And sometimes we'll also upload support information, things like what Rick just posted. He put a link, I think it was a link to an article. So you'll see Rick doing that often. He'll cite some information into the chat. So we'll include that in the resources page as well. So just knowing that when this is over, all the information does not go away. You can access it again at any time you want or need to. And then Melissa also provided our contact information. So if you have other questions or follow up, you can reach out to us directly as well. Any other questions or comments for Ryan? Yes, ma'am.
I was just going to say, I did a quick lookup and it pulled up something quickly from PubMed, and it said of the benzos, the safest in pregnancy and lactation was Valium. Was Valium for pregnancy, but not for lactation because of the sedation and risks afterwards for the neonate.
Excellent.
Not any is good, and I'd have to research further myself.
Yeah, well, a lot of times it's that harm reduction approach. Like, we'd rather it not be, but when it is and it has to be, then this is the safest way to go about it. So keeping that in mind, I think, is very important.